Yeah, well, I'm sure we'll have a few more folks hop on, but in the best interest of time, I'd love to get things rolling. I'm pretty confident as I look at this room that we've worked with each and every one of you at some point in some capacity. And so with that, I'd love to say, obviously, the Lynn Institute is a nonprofit organization here in Oklahoma City, and we work with vulnerable populations. And our goal is to increase access to resources and find ways that we can bridge gaps between issues and communities. And so we've largely been working in Northeast Oklahoma City with partners that have been in the community for years. And we found another partner in Centennial Health who has been doing fantastic work in providing healthcare to the community. And so I'm very pleased to be able to partner with them and many of your organizations who are on the call. And so with February being Heart Health Month, we really wanted to find a way to be able to discuss issues related to heart health and bring light and hear from an expert on the topic. And so Dr. Lunn, as the clinical director of Centennial Health, we're excited to hear from you. I'm always eager to learn these foundations of wellness programs. Every month we take the topic of focus and find a professional who can kind of delve into the topic and teach us a little bit on what's going on. So I'm excited to hear from you. Thank you so much for being on the call with us.
Great. Well, thanks. Are you guys ready to start?
Yeah, I think, in the best interest of time, we can get rolling, and I think we'll probably have some more folks come on. I think that works well for us on our end.
Okay. Well, I will make it, I can make it long, but I will try to make it very brief, very, very brief, because it just gets boring. So I think, so first, thank you very much, Anthony, for inviting me. This is one of my go-to things. I really do like talking to folks. A lot of my patients know I like to talk, but I love the fact that this gives education to people before they have to have a problem. So, and particularly this particular group of people may not realize that if you look at African-American women, they have the highest degree of cardiovascular disease in the world. In fact, one time, Lawton, Oklahoma set the record in the United States for Black women suffering from cardiovascular disease. And there's several things that I will talk about that was one of the reasons for that. So we're saying heart disease. A lot of people think heart, I think cardiovascular. So the cardiovascular system, by definition, I'm going to quickly go to what we don't want to see, and then we'll go back to how we not get there. So the first thing, people know what a heart attack is, or they think a heart attack is. They also, I put in the same category as strokes, brain insults, and I also put in the same category as peripheral vascular disease, or where people lose their feet and their limbs and have all kinds of problems. None of those are very good. they're really bad, but they are stuff that is the end result of a lot of things that do go on that are preventable. So the first thing is people think about cardiovascular disease and plaque buildup. Plaque is you've got this nice vessel in your artery that feeds your heart, and it gets plaque on it. That's actually a normal occurrence. I remember when I was in medical school, they were doing a study on Vietnam War veterans, it was actually autopsy on young people, and people age 20 have plaque. So plaque is normal. We just don't want too much of it. And I can talk to the pathophysiology of how the plaque starts a little clot, and then it goes off, and then it invades and stops up another vessel, and that's a heart attack or a stroke. So really you want to try and prevent that from occurring so that you don't end up having a heart attack or a stroke, or in my case, what I like to call people cardiovascular cripples. 20 or 30 years ago, if anybody in here is as old as me, will know that we used to give nitroglycerin out all the time. And you'd see, if anybody's old enough to remember Sanford and Sons, you remember Fred go, Elizabeth, and he was taking a nitro. That was actually very common. Most people have not seen that in a while. And he said, well, how did it go away? Well, it was control of cardiovascular disease, and controlling the risk factors is the reason you almost don't see people with walking around with what we call unstable angina or chest pain anymore. So obviously that's the bad stuff. The good news is that most of it is preventable, or you can delay it till you're 95 years old when you don't really mind. I don't know if you ever not mind, but you know, it's better to have vascular disease at 95 than 55. So the first thing is prevention, and that's lifestyle. And I kind of wrote this out in the number one thing you can do. The number one thing you can do is not smoke. Smoking makes a lot of doctors a lot of money. And we're specifically talking about cigarette smoking. We don't know about vaping. We don't know about marijuana. I I wouldn't chance it. So smoking, if somebody says I want to do some prevention, the number one thing to do is to either not start smoking, or stop smoking, or not start, or not be in a household with somebody who smokes. And that's the best thing we can do for our children and grandchildren, is not smoke around them. The second thing would be exercise. And when we say exercise, people, think that you need to do a lot of exercise, but really we're talking 30 minutes of aerobic exercise, 30 minutes 5 times a week. And it doesn't have to be all at once. It could be a 10-minute walk 3 times a day. But we're just really talking about just a walking, which a lot of us don't do. But that's the second biggest thing you do, is prevention. Third thing would be obesity. And really, we want to make sure that we keep our waistline below 40 in men and women. But that would be the next thing to do. And then we talk about diet. Diet's always one that, people think, well, what's a heart healthy diet? It's basically eating your fruits and vegetables and laying off anything really good is bad for you. My favorite thing, when people say, well, what shouldn't I eat? Well, I would look at a donut. A donut's full of fat. It's full of carbohydrates. We add some sugar to it and some salt, and it is delicious. If we really like it, it's bad for us. So, that's just my go-to thing on that. We talk about low salt diets and things like that. And basically, people get into calculating how much salt they're doing and this and that. If you're using the salt shaker at the table every time you eat, that's bad. If the salt shaker's on the table and, oh, this isn't just salty enough, that's bad. You shouldn't do it. Now, the next thing you can't do anything about, but you can be aware of, which is genetics. If you have a family history, particularly in this particular group of people, if you have a woman who's had cardiovascular disease, any of the three I mentioned, peripheral vascular disease, heart attacks, or stroke before the age of 65 in your family, you're at genetic risk, and you should start taking some precautions. That would be and that's kind of the last thing I would do before I get to some of the comorbid things. And this is where people in the adult sphere really kind of get honed in. This is where you end up seeing me. The first thing is hypertension. Hypertension is fairly rampant in the country. It's a disease of chronic illness. And we talk about chronic illness. So I have medical students, and they would see me and they say, Doc, you sure have a lot of patients with hypertension. Well, if you live long enough, you will eventually get hypertension in general. It's a side effect of being chronically alive. Even when you're doing your best to try and prevent it. And I'll use myself as an example. Since I've got all this stuff too, because I've got the family history and I like to eat and all those things. I developed hypertension 4 years ago. Even though I routinely exercise, I'd lost like 70 pounds from 20 years ago, I still developed it. Now, in the same instance, I have 2 younger brothers who developed hypertension 10 years before I did. So I staved it off for 10 years, but eventually I got hypertension. Wasn't exactly my fault, but I'd rather be alive. The second thing is diabetes and trying to prevent diabetes, which goes back to the exercise. When people talk about trying to prevent diabetes, and we're specifically talking about type 2 diabetes, the one people get when they're age 50 or overweight, a routine exercise protocol prevents diabetes much more than almost any other thing. Again, I'm an example. Everybody else in my family has diabetes. I don't, as of yet, because I exercise. Um, so that's one other thing to do. Another risk factor, which most people don't really realize, is rheumatoid arthritis, not osteoarthritis, but the kind that affects your joints in your hands and things like that. That is also a risk factor. Um, then we start talking about the basic treatments. The basic treatment is to keep your blood pressure in that range below 140 on the top, below 90 on the bottom. Um, Aspirin, interesting. Now, looking, and I've taken aspirin for years and recommended it, but right now, if you don't have a huge risk factor, like a family history or have had a heart attack, there's no reason to take an aspirin every day until after you've had a heart attack, which is kind of, so you can plus or minus, controlling the blood pressure, of course. And then the latest thing is statin therapy. When they do studies looking at statins and cholesterol agents, they're really showing that statins lower the incidence of cardiovascular disease, whether people have high cholesterols or not. There is some debate on whether we should just keep people on statins all the time, or whether statins should be like fluoride, where you just literally put it in the water to decrease the incidence of heart disease. So anyway, that's my short and long spiel. And I'd be happy to talk about questions if anybody has some.
Yeah. So actually, a question we just had come through is, what is a statin?
Okay, so a statin is a cholesterol medicine, and I'm sorry I did jump there. So so cholesterol is fats in your blood. You have two types of cholesterol. You have the LDL, which is the bad cholesterol that gets on the vessel. Then you have the HDL cholesterol, which is good cholesterol that takes the fat from the vessel. You can have, and that's the reason we don't use the number of the total cholesterol anymore. It used to be, is your cholesterol below 200? Well, now we know that you can have like I have people with a cholesterol, HDL cholesterol, I'm sorry, a total cholesterol of 250, but their HDL cholesterol, good cholesterol, is so high, it offsets their bad cholesterol. I also have people with a total cholesterol of 200, which is technically normal, but I look at their LDL cholesterol and it's 170 and their HDL is really low. So statins are drugs that reduce the LDL cholesterol. There is, and that's the bad cholesterol. There is almost no drug that increases the HDL, good cholesterol. The only thing that increases the HDL of good cholesterol is exercise. You get kind of see how I wind back to exercise every time. Okay. Other questions?
Yeah, a question I have is, so driving in the car, or listening to music, I sometimes hear these ads about heart scans.
Oh yeah.
I hear them quite frequently, and so a question that I've got is, when it comes to heart scans, is that something that a blanket across the board everyone should be doing, or is it case by case basis? What is that? How should we be thinking about heart scans related to our health?
So heart scans, they're kind of my nemesis. So heart scans are great when you don't have a primary care doctor. If like a lot of people in this United States do not have health insurance, so they can't sit and talk with somebody like me about the risk factors. Now, I tell my patients don't get one because I'm already looking for all the risk factors. So if you look at if I do my job right and do my assessment, I can tell you what their heart scan is going to show. Now, if you don't have a physician, then you can go ahead and get a heart scan. It'll tell you stuff, how risky you are and what you should do. So the heart scan is kind of I find it of no clinical use for me, but most of my patients are insured and they have me. For the regular person on the street that's wondering, should I quit smoking? Well, the first answer, they already know they should. Should I exercise? Well, they already know they should. The heart scan may, at $50, show you a reason to do that. Now, one of the other problems I have with heart scans, and I don't mean to talk ill of my colleagues, but a lot of times the heart scan scares the bejeebus out of somebody, and then they run to do a procedure. Well, it looks like you've got, and I've had this with patients that had no vascular disease. I had this lovely nurse. Now she's 70 years old, but I was talking about exercise. She walks 3 miles every day, just fit as a fiddle. She went and got a heart scan. The heart scan showed she had blockage. Well, I knew she didn't have blockage. She had no symptoms, nothing else was going on. So what happens? She ends up going to see a cardiologist. The cardiologist says, well, the heart scan's abnormal, but you look good. Well, the only way he could tell that she didn't have cardiovascular disease, and he did several tests on her, is to do a heart catheterization where he put a thing in her groin and went to her heart to show that she had no disease. Well, that was a risk to her health, and it was also a waste of money. She got the heart scan for $50. In the end, it was $15,000 to prove that I knew what I was talking about. So anyway, that's the short spiel.
And so within that, if you're speaking with your doctor, if you're working with your doctor, refer to your doctor for guidance. But if you don't, that may be a good place.
It may be a good place to start. So again, double-edged sword.
Another question that just came through is the blood pressure medicine, and excuse me, I'm gonna butcher this, lisopronol, good to take? Are there some worries related to allergic reactions or that sort?
But that's one of my favorite topics. I just talked to a guy about that. So lisinopril is a great blood pressure medicine, and I will tell people why it's a great blood pressure medicine. It has a couple of side effects that you can get that are generally, when I say generally, they are not deadly. The first thing is that you can get a cough. That's called an ACE inhibitor cough. And we take people off of it. The other thing is called angioedema, where your face and lips will swell up. It looks horrible. You'll see people on YouTube and Instagram or whatever, where they're showing their face all swelled up and say, well, this is lisinopril, I shouldn't take it. Let me tell you, that is a very rare reaction. It does happen. I still use lisinopril, but the reason lisinopril is still a medicine that I like to use is because if you have diabetes, it protects your kidneys against renal failure. If you look at dialysis units, overwhelmingly, you're going to see African Americans in there. Why is that? Well, they have diabetes, but they also did not get preventive care on protecting their kidneys from their hypertension. Lisinopril is the only drug proven without a doubt to protect your kidneys. There are some other drugs that we think they do it, but we're not sure. So when I see my patients, if they have diabetes, I still use lisinopril. I take into account that, yes, you could have an allergic reaction, but you won't die. And it's better to have an allergic reaction. I take you off the medicine than be on dialysis. So that's a great question. You also get the same thing about amlodipine, which is a common blood pressure medicine used in African-American folks. Not my favorite drug. It's a great drug. When we talk about side effects of medicines, people always say, oh, I don't want a side effect. In hypertension, you do want a side effect. Lisinopril protects your kidneys. Beta blockers, metoprolol protects your heart from various things. There's certain other blood pressure medicine that protect you from strokes. Amlodipine is a great blood pressure medicine to just lower your blood pressure, but it has no good side effects. So a lot of people start with amlodipine on African Americans. The only side effect, a bad side effect it has is sometimes your legs can swell. But when you're talking to your physician about the blood pressure medicine, first thing, you need to make sure the blood pressure medicine is going to be effective. Then when you say side effects, people always ask me about side effects, but they never ask me about the good side effects. There's good side effects of medicines besides bad side effects. Did I go on too long, Anthony?
No, you're perfect. That's the whole goal of this. We really want to create opportunities for us to kind of discuss things that may not happen in regular conversation. I know that I probably wouldn't have been able to get information on the medication described otherwise. So no, thank you. I appreciate it. along those same lines, and you know, I'm gonna put the question out there, and you answer it, you know, as you seem fit. Is this person goes on to ask, should you take blood pressure medicine if your blood pressure is a high 137/80 and sometimes might go up to 140?
Well, the general answer, if that's an accurate blood pressure reading, you're controlled. Now, I'm a family medicine doctor, and so I'm a little different than a cardiologist. A cardiologist will want your cholesterol at 120 or 70 all the time. Now, I don't push it that low because then you actually can get some side effects of medicine. But that description, if that is an accurate reading, and again, I don't necessarily check the trust the home blood pressure readings. I only trust myself. That is controlled blood pressure. I would not do anything with that.
And so with that, another question that I have is, I know, and I'm sure we can all think of, you know, the unhealthy foods that are going to put us in harm's way. But as we talk about the heart, are there go-to foods that we might try to incorporate into our diet that might do a little bit of good for our hearts as we, you know, are trying to get better or to think about our heart health?
Well, there are a couple of things. The first thing is fresh fruits. That's my go-to thing. You know, that a whole eat an apple a day is very reasonable. If you know, a lot of times we're eating processed foods for breakfast, but I tend to eat fruit for my breakfast. Fruit for your snacks. That's a go-to thing. There are some foods that are better than others. There's actually one manufactured food that lowers your cholesterol, which is called Smart Balance butter. It's a synthetic butter in the butter aisle. It actually will lower your cholesterol. Um, Now, which is great. There's been a lot of things that we used to think were great that weren't so great, like omega 3s, which is a big thing. Shows, you know, omega 3s just don't really work. Niacin, which is another one. I used to prescribe that all the time. It doesn't really work. But if you say go to, we know what's healthy and we know what's not healthy. If you have to open it up and if it comes in a bag, it's not healthy. Okay. So,
No, that's good. That's good.
yeah, yeah.
Another one that I've got for you, and if you have any questions, please put them in the chat or feel free to wave at me if you're listening in. But another one I've got is, I know we've been using the term cardiovascular disease. When we hear, you know, other conditions, and I'm assuming other conditions, so please enlighten me. I've also heard of coronary artery disease. How similar illness, totally separate, and what is it?
So the same thing. So cardiovascular disease is just a general term. Under that vascular is the arteries. We're mostly worried about the arteries. Um, the arteries are the things that push blood to end organs, to your kidneys, to your heart. Um, those are the ones we really only worry. The venous system is the stuff that draws blood away. So now, the big disease in that is deep venous thrombosis, DVT, which is technically a cardiovascular disease, but it's not the one we really worry about so much. Is a completely different thing, and there's different prevention for that, except for the only prevention for it that's common is, again, circling back to exercise. People who exercise don't tend to get DVTs. So cardiovascular and arterial disease is basically the same term of what I'm worried about.
Okay, yeah, and Dr. Lunn, oh, Mr. Ray Beachy, do you have a question?
I do.
Oh,
Dr. Lunn, the comment you made that really surprised me was that most of your patients have health insurance.
Yes.
And it's my opinion that a high number of people in Northeast Oklahoma City aren't that fortunate to have health insurance. And that could be an inaccurate assumption. But how, if it is correct as an assumption, what can we do to reach out to people without health insurance and help them understand the importance of practicing everything that you've discussed this morning?
Hmm. Well, that's a great question, because I know people think that that's not such a thing, but the Northeast side. So when I talk about health insurance, I mostly talk about Medicare.
Okay,
I do mostly geriatrics, so people
okay,
over 65 with underlying health conditions get health insurance through Medicare and Medicaid. Those are both insurers. Now, they are not the insurances that a lot of people think of, but it really is insurance. Uh, and to be honest, I practice in a place in my I came from Kansas City, where I practiced with a population that did not have health insurance, and it was a struggle. And I don't know how to address folks who don't have health insurance. To be honest, I'm busy enough doing what I'm doing to figure out the other things. So Anthony may have better answers for that than I do.
Yeah, I know from Lynn Institute's perspective, when we talk about gaps that do exist, we're constantly trying to find ways to pull partners in. And so when we talk about, programs like our On the Road to Health program, where we're partnering with Centennial Health to try to find those free resources that do exist. And so one example of something we've been trying to do is for our On the Road to Health, which is a program for ladies in Northeast Oklahoma City between 25 and 65 who might have some comorbidities, is to give them a bunch of lessons and learning opportunities related to health and getting healthy, but then also do regular health screenings, which we're doing on site at Centennial Health. And then from there, if they don't have health insurance and their readings are high or maybe a cause of concern, or even if they do, from that point, either referring them to their physician or connecting them with some free resources. So I definitely say it is right to your point, when we locate folks who, are without, trying to simply find those resources and connect them. And so even with that, really it's a matter of locating the individuals and then making sure that we don't just find the problem, right? Finding the problem is just that first step, but then finding a helpful way to connect them to the free resources. And so it's not an easy dilemma, especially with the current climate and crises that we're facing. But I think it's a matter of trying to collaborate, trying to find partners like Lynn and Centennial and other folks in organizations in Northeast that can kind of collaboratively locate and point people in the right direction to the resources that exist. And so, no, good question though, Ray. Great question, because that's really what we want to do. We want to, folks, like, it's funny. My wife, whenever I'll say, I'm not feeling well or I'm under the weather, we'll go to the doctor. We'll go to the doctor. Sometimes I question whether or not I would be as healthy as I am fortunate to be right now if it weren't for my wife pointing me. So even for those, I think, who do have health insurance, making sure you make good use of it, I think is an important thing to discuss as well. And so, Dr. Lunn, with that, another question I've got for you is related to stroke and heart attack. And so I know I hear them both as separate terms. I'm understanding that they internally are different. What is the difference between a stroke and a heart attack?
Okay, so just in general, both are called thrombotic events. Thrombotic means a blood clot or a scab. Like, you get a scab, right? So if you imagine the scab inside your vessel and it flies into a open pipe and it clogs it up, then you can't get any more blood flow. So thus far. Now, when I was a kid, I was a pretty bright kid, but I wasn't the smartest kid. So I would tie a string around my finger just to see what happened. And after a while, it started to hurt. That's essentially what a stroke or a heart attack is. It happens in the heart because you have blood vessels going to your heart and you basically lose the blood flow. The same thing happens in the brain where, and I'm talking about thrombotic events where you get a clot going to the brain, it doesn't get blood flow. Now, the brain has two different types of strokes, and I'm talking about embolic. You can also have a vascular stroke where it bleeds. So there's a slight difference, but the risk factors that I'm talking about are basically the same. So just no blood flow, all of a sudden, heart attack, bad.
Yeah.
Yeah.
Well, thank you. And I've got one more question for you. And so this is relates to the use of supplements.
Mhm.
And so I know supplements are very popular. I know some more recommended than others. Are there any natural supplements that you'd recommend for folks to take for heart health?
No. And I'll give you a hard no on that because my academy is my academy, the family medicine people, right? So one of the things that we have a struggle with is our patients affording and being able to take their medicines. Now, we live in America. I've never treated scurvy or rickets. Everything's everything is vitamin fortified, our bread, our Lucky Charms, and things like that. So we don't really have vitamin deficiencies or supplement deficiencies. Now, do they harm? And I also have a little problem with the way that the supplements are regulated through the FDA, not the drug enforcement thing. So all supplements have to prove is that they won't kill you. They don't have to prove that they will help you. So the only people telling you that they will help you is the person who manufactures it. So when I have a patient come in, and it happened this morning, he's got the 2 Walmart sacks, new patient. One is the pills that the doctors prescribed, and then the second is the supplements that he's taking to try and keep himself healthy. And I asked him, how much are you spending on the supplements? Well, he's spending more on the supplements than the drugs that I recommended. So from a doctor point of view, I find that, I'm fighting the economics of trying to prescribe medicines that I know for a fact are safe and will help the patient versus the medicines that have been sold to him by whoever. Now, do I take people off of supplements or anything like that? The answer is no. They can take supplements if they want, but in my opinion, and this is my opinion and my academy's opinion, supplements are, if you're taking more supplements, if you're taking a sack full of supplements, you're not really helping yourself. You may think you are, and and it's okay to do that if you feel better, but I would not, I just can't think of any supplements I would recommend to my family members at all. So that's a
Well, Dr. Lunn, we really appreciate you. I know we wanna do all we can to get information about being healthy. It's related to our heart and other areas. And so I really appreciate you taking time to be on, answer these questions. So you all know, Centennial Health and the location that, and Dr. Lunn, correct me if I'm incorrect, but Dr. Lunn is primarily working out of and stationed out is in Northeast Oklahoma City, and they're at 1720 Northeast 23rd Street. I'd love to connect you with Greg Jones or Dr. Lunn if you have any questions, or if we can find ways that as organizations we can continue to partner. If you have more questions or want more information, you can go to centennialhealth.com to learn about what they've got and how they've been operating. But if you also would like to discuss that with me, I'd gladly talk with you. So you guys know these Foundations of Wellness programs will continue to take place every month. And so what we'll do is we'll keep everyone in the loop as they continue to get developed, and we continue to put the plans in place for them. But Dr. Lunn, thank you so much. It's a pleasure to hear from you. I hope you're staying well. I know that you and those in your field, especially this past year, have had a trying time. So I thank you so much for your work and doing what you can to help keep the community healthy.
cool. All right, thank you. This is always fun. Invite me again.
Will do. Well, you might regret telling me I can do that, sir.
I might, but probably not. So, all
Right.
right. Well, you guys take care. I'm gonna go see a patient.
Yeah, thank you so much, Dr. Lunn. Everybody else, thank you so much for being on. You guys stay well, and we'll look to keep you informed about our next opportunities.